It's my privilege to introduce to you our keynote speaker, Dr. Jody Oakman. Jody has a Doctor of Philosophy from La Trobe University in Australia, a Master's of Science and Technology in Ergonomics, a Bachelor of Applied Science in Physiotherapy from La Trobe University. Jody is a senior lecturer at the Center for Ergonomics and Human Factor at La Trobe University and is the postgraduate coordinator for the Ergonomics Safety and Health Program. Jody has worked extensively in industry as a consultant ergonomist to many organizations. She is a qualified physiotherapist and has a PhD in the area of the aging workforce and the impact of organizations on their employees' retirement intentions. Her research is currently focused on the impact of the psychosocial and work environment on musculoskeletal disorders and strategies to improve risk management in the workplaces. Hence why we have Jody here today, and we're really grateful for her to have taken the time to come from Australia to speak to us today. Jody?
Oh, do we have are we using a? Yeah. Okay. Right. Okay, it's good when technology works. Right. Well, thank you for that welcome, and thank you, CRE-MSD and University of Waterloo, for inviting me to come to sunny Toronto. Pleased. Very excited. Tomorrow will be 9, so this is great. I got a little bit of a fright when I looked at the weather 2 weeks ago and discovered it was -14, and Catherine said, actually it's -25, which didn't help. Anyway, here we are. As Catherine said, I coordinate a program of ergonomics, safety and health in Victoria, Melbourne, so down in the south. As part of that, we have a research program on musculoskeletal disorders, and that program's been going with my colleagues who started that for the last 15 years. So I'm going to talk a little bit about that, but I'm going to talk about where we're at in terms of musculoskeletal disorders. I was trying to quickly think of a car analogy there, and I think I'm going to provide the chassis so that we have some support for what we're going to talk about later. So I'm going to ask 3 questions of myself and hope that at the end of that I've actually answered these. Do in fact we have a problem with MSDs? And I would suggest the fact we're sitting in the room talking about them, and the fact that I was talking in Brisbane at a very similar event last week suggests that we probably do. What does the current evidence tell us about musculoskeletal disorders, and does that actually reflect what we're doing in practice? Now, we're doing good things, both here and in Australia, but is there more that we can do? And if we want to see change continue to improve, what extra things do we need to do? So what are the gaps, perhaps, in the strategies, if there are any? One of the things is that both Australia and Canada, we have an ageing population. I don't think anyone can dispute we're all getting older, but so is the population as a whole. Our Treasurer, who won't mean anything to you except that he does, he's known for his, we say foot-in-mouth disease statements in Australia. He said at the end of last year that we were all going to have to work till we're 70 and that we were probably going to live till we're 150. Now, this is an example of his statements. I agree with the first. I think we are going to have to work for longer, and I think that anyone sort of my age and below, we're probably looking at retirement of 70. Like, we don't have mandatory retirement like you, but access to the age pension. Now this causes some issues. One is that we need to want to work that long. That seems a long way away for me at the moment. And the other thing is we need to be able to work for longer. And so as people working in occupational health, we have some control over the second one. So we need to be providing work that people are able to do. We need to not injure them so that they can make choices about what they do. Now there's a whole other dialogue about whether or not you're going to be able to be a roof tiler when you're 70, but we're not going to discuss that today. In general, our philosophy should be about prevention of musculoskeletal disorders from young right through the life course, because when we start work, those workers, we often distinguish between young and older workers, and I'm going to suggest that we actually need to look at just workers and what they can do. And as an ergonomist, I'm interested in match, and I note that there are other ergonomists in the room, so we're interested in match between people and environment. The way we work has changed in unprecedented times, and I love this academic sitting there with no computer reading. As an academic, we rarely get time to read things now, we scan like most other people. But we are now working in environments that are very different. We are exposed to a whole range of hazards that I don't think we know a lot about. We work very differently. We're on call for all hours of the day, and I was listening to dinner conversation about where people take phone calls, and people can read into that what they want, but people take calls at any hours. Some of us will remember the time that when you left the office, people would never ring you at home to ask you something, they'd just wait. Now we're expected to respond, within the hour, please. So this means that there's a lot of things I don't think we fully understand in what we're actually exposed to. We have a pretty good understanding about the physical nature of work, but these other aspects are somewhat new, and we know something about them, but not everything. So my job here is to remind me of home, the Lego. When you've got it, you curse it, and when it's gone, you miss it. My job is to build a wall of evidence that supports what we should be doing in terms of practice, in terms of MSDs, and hopefully make that nice and strong so that it underpins what we do and the decisions that we make when we think about our risk management programs for MSDs. So, what are they? Most of us know what they are, and there's reasonable consensus around the definition that these are work-related musculoskeletal disorders, and they affect a range of body parts, tendons, tendon sheaths, muscles, nerves, etc. But they're complex, and one of the problems we have is that the compensation systems that most of us operate in, and there are differences but a lot of similarities between Canada and Australia, is that they require us to pinpoint a point in time at which the injury occurs. And I'd suggest that most injuries or disorders are more complex than that, and they develop over time to cumulative exposure to events. So it's very difficult and somewhat misleading to try and attribute a point in time. So this single event notion doesn't really, sometimes it does, but not always. And so how do we know whether we've got an injury or in fact a disorder? We like to have diagnoses, and in the day of Dr. Google, what happens when something happens? You go and you try and find out what it is. The problem with musculoskeletal disorders, those clinical diagnoses are notoriously unreliable. There's plenty of evidence to suggest that MRIs and X-rays don't really always tell us what's happening. The clinical picture is often more accurate, but what happens is in the sort of systems, the compensation systems, we're looking for a label, but I suggest that that's actually what we don't need to be doing that. What we need to be doing is managing symptoms that are indicators of potential musculoskeletal injuries, and potential claims. And so our focus needs to be way down left of that arrow. We need to be really starting when people indicate that there might be an issue. So well before we have a diagnosis, and certainly well before a person gets into the messy claims cycle, which we know deals with people not always particularly well, and so we don't necessarily get good outcomes once people go to claim. Well, sometimes we do, but not always. So we need to be really focusing on what's happening, what are the exposures that are happening, and what can we do in the workplace at that particular point, so down left. We also know that cumulative exposure to hazards or cumulative injuries lowers the threshold, so it makes us more likely to have acute events, and we can all think of examples where there's been some really small trigger that has resulted in what seems to be something somewhat out of proportion to the event. And so an ICO statement in 2012 suggests that what we need to be focusing on is just musculoskeletal issues, regardless of that are at risk of working, regardless of what the clinical diagnosis is. I try not to. So anything that's at risk of worsening with work activities that affects workability or quality of life. Like in Canada, like Australia, we have a system which distinguishes between work and non-work related, and this distinction can be somewhat challenging. We all have cases that we're not entirely sure what the causes are. So I'd suggest that what we need to be thinking about is what's happening, what we're seeing in our workplaces, and not relying on the clinical diagnosis, because this may take us down a garden path when in fact we know that many times it's the straw that breaks the camel's back. So, are they a major problem? Well, certainly we know that the population is ageing, we've talked about that, and we know that unfortunately many chronic problems are exacerbated as we get older. There are things that get better, but there are things that don't. This is a little difficult to see in this room, but really what I'm just pointing out here, that there are similarities in what's happening to our population and what constitutes our work populations. The bottom right is Canada and the top left is Australia, and so the proportion of older workers in Australia is growing, and we can see there that for you it is too. Now the scales are different, I'm sorry, that's because unhelpfully our compensation bodies didn't do their graphs on the same scale, so I couldn't fix that. So anyway, we are seeing more older workers in our workforce, and most of us would acknowledge that that's what we're seeing. But as I said, this is something we have to manage. In Australia, musculoskeletal disorders make up about 60-something%. That's conservative, because there are other categories which are probably musculoskeletal disorders, and we're reliant on how the data is coded, a bit like here. What's of interest is that mental health disorders in Australia are currently quite a big focus, but in actual fact they're only about 6% of the total claims, the lost time claims. However, they tend to be expensive and messy. People are off work for longer, so they do receive attention for good reason. But if you want bang for your buck, musculoskeletal disorders are still the area that we really need to focus on. Now, in Canada, about 40% from the data that I could get, sorry, Ontario. It was a little tricky for me to get my head around the data here. We have a nice convenient website at home that gives us Australia-wide. I was sort of struggling here, but basically the message is that you have a problem, we have a problem, and so does the rest of the world. The only reason we talk about developed countries and not developing is because we don't really have good data for developing countries. And if you think about the sort of work we send to the developing countries, i.e. add the jobs that we don't want to do anymore, they certainly have a problem. It's just the data isn't there. So, what we're going to talk about is now about what are the causes, what are the predictors of MSDs. So the data underpinning what should be driving what we're actually going to do about this particular problem. And this 1995 diagram is here not because I forgot to update my slides, but just to remind us that we've known for a very long time that there are many ways to for the development, many pathways to the development of musculoskeletal disorders. And we can see here at the bottom that there are a whole range of different factors around supervision, computer monitoring. This is back in 1995. We've got better at computer monitoring. We've got more accurate, and we tend to use it quite widely. And all of these factors, these workplace factors, can result in physiological changes. So changes, these are stress responses, and these stress responses can then result in the development of musculoskeletal disorders. So these are not physical aspects of work, these are other aspects of work. If we look in 2001, most of you, I'm sure in the room will have seen this. I mean, we use this a lot because it was a very pivotal piece of work in 2001. This group of experts in the USA got together and reviewed all the evidence and came up with this particular model. And what was interesting that in 2001 there was acknowledgement that psychosocial factors, called organisational factors and social context, but that's what they are, were indeed related to the development of a physical disorder, as well as, of course, physical loads. We mustn't forget that. And so again, we see these physiological changes, the person level, resulting in mechanical strain, fatigue, and then the outcome of discomfort, pain, or musculoskeletal disorders. Of course, there are individual factors, so age, gender, genetic predispositions, which we can't control. So in workplaces, we need to acknowledge they're there. And this is our work, this is the conceptual framework that underpins the work that we're doing in terms of musculoskeletal disorders. So it's a simplified version. We're ergonomists, so we're interested in fit and the role between the individual and the match between their organisation and what happens. And of course, we all know if you improve that match, then you reduce the loads and the stressors on people, and then reduce the likelihood of people developing musculoskeletal disorders. I'm not going to go through this, but just to remind us that there are many pathways through which this can happen. So many different hormone pathways, changes, and resultant musculoskeletal symptoms, so muscle pain or tunnel syndrome, so the carpal tunnels, inflammation or impaired muscle tissue and repair processes. I'm just going to skip over that one. So there are a couple of categories. So we're interested in manual handling hazards, of course. We're very comfortable with things too heavy, too hard to move. And then there are these psychosocial hazards. But what are they? And if you look for definitions, they will vary. But largely speaking, they comprise of organisational or work organisation, or how work is designed, and then social context, so the sort of support, communication and relationships with managers. So things like the working hours, job demands, so workloads, how much control we have, and pace. and conflicting work demands. And of course there are many models exist which talk about demands versus control, and if we give people more demands but we give them control, then does that make that better? But we are finite beings, I remind people, so we do not have unlimited capacity. And then social context, the communications with management, how valued we feel, and culture. And the case studies later on, I think, will bring out some of these, how important these are in terms of both getting projects going, but getting them to work and getting sustainable change. And the thing about psychosocial hazards is that they're within the control of many managers and supervisors, both in creating them, but also in getting solutions to the problems. And so we just need to remind ourselves that these are issues that we need to work on. So one of the things is that there are many hazards, and one of the issues is that these can interact or they can be additive. And so if we think about both identifying and then controlling hazards for MSDs, if we take a singular approach, we're unlikely to be as successful as we could be. We might be, because we might get some of the problem identified and solved, but it's likely that there are many components. They're multifactorial and they're very complex. And so we can't treat MSDs in the same way that we might treat, for example, some chemical exposures where it's straightforward. You get exposed to this much, this is the outcome. So there's a whole raft now of research evidence about what are the predictors or the contribution of different predictors towards increased MSD risk. Maris, I'm sure people in the room will know William Maris's work. He and others undertook a big review in 2009 looking at predictors, what was the contribution of both psychosocial versus physical hazards or factors. And we can see there that there are a wide range of contributions which depends on the particular study. And we'll see this is a pattern across occupational health research. I'll come back to that in a minute. This study, which was undertaken in very physical work, so you would expect that the physical contribution towards development of new cases of back pain would be high, and it is significant, but job intensity was a stronger predictor of development of new cases of back pain. So this is about how hard we make people work. This review looked at psychosocial factors only on musculoskeletal development. It was a meta-analysis, so it's a fairly rigorous, systematic approach to looking at a whole range of data. It's an efficient way of reviewing, the data quite quickly from a reader's perspective. And we can see there again this issue about job demands being one of the very strong predictors of development of musculoskeletal disorders or the likelihood of developing low back pain. In our work, we've looked at, we've pulled our data over our last studies where we've looked at manufacturing, logistics, hospitals and ambulance services. And what we do is we've been surveying workers on the physical, we have a physical hazards scale, and then we look at a range of hazardous states, and we look at a psychosocial measure, and then a pain outcome, a discomfort measure, which we use as a proxy for MSD risk. Pain measure is a score of frequency and severity across 5 body regions, so it's got a score out of 60. And we use a work organisation assessment questionnaire, so across a number of domains, a number of psychosocial domains, so relationships, amount of support, workload, and a little bit on the physical environment. What we found was, when we looked at this data, what we were looking for is where would we, both what were the predictors and where would we pitch our, target our interventions. What we found there was that these are beta values, but what they're the contributions to increased MSD risk. we find there that the psychosocial and the physical factors contribute very similar amounts to the model. Job satisfaction is negative, so low job satisfaction, increased risk of MSD, a reasonable predictor, but not as strong as the other two. And age was significant, but not strongly so. So I haven't got that there on the model. What we found was that we needed to target our interventions at job levels, so looking at what individual jobs were doing and then developing the interventions at that level, and I think that'll be supported later on. Now, some of you will say there's a lot of variability in those results, you know, there's a huge range, but I would suggest that we should expect that, because in occupational health research it's very messy, the real world is messy, people don't, we use different measures, work environments differ, you know, various sites, differ. In a recent study in the aged care sector we found, you know, one organisation, different sites, completely different cultures, and so you would expect to find a big range in your results. So, it's clear that management, assessment and management of psychosocial hazards is essential. It's not optional. I think we can see from those results that we'll get we'll get some gains with managing physical hazards, but if we completely leave out the psychosocial hazards, we're unlikely to be as successful as we could be. Doesn't mean we won't be, it's just we could probably do better. If we identify single hazards, we may miss the big picture. So we really need to be looking at that holistic model of management. One of the issues is that a lot of our tools lead us down that path. I'm an ergonomist. I understand that the tools and the limitations, and we have some problems in the tools that we have available to us. So what are we doing in workplaces? Most of you will know that better than me. One of the issues is that we don't have a lot of evidence about what happens in the real world. We don't tend to write about it, and that makes it difficult then to draw upon to share with others. That's why things like today are really good. But when you're looking for examples to use in the scientific literature, they are limited. There are some reviews. We have been undertaking a review with our own centre. When we do work, we've been looking at what people's policies and procedures, their risk management processes look like. And in a recent study in the aged care sector, we developed a matrix. We undertook a qualitative review of their evidence. What we were looking for is what was covered in policies and procedures. Now, I'm not suggesting at all that policies and procedures are the be-all and end-all, but we know that when we have good performers versus poor performers, that poor performers at best are very compliance-driven, so they will use what they've got. They will follow their policies and procedures, so if it's not there, they're probably not going to do it. Good performers go beyond that. They do more than what they need to. And what we found in this, we were looking, of course, for coverage of physical and psychosocial hazards, matching the model that I presented up front. And what we found was that there was very limited coverage of psychosocial factors in relation to MSDs or mental health disorders as an outcome. So what's apparent in the literature is that there isn't one way to manage MSDs or to develop programs, and they need to be tailored. That is evident from the literature, and the use of participation is really important. And I'm not telling anyone in this room about that the workers themselves will often have the best solutions. So the issue is about being able to harness that. And I'm just going to talk now about a couple of Australian examples which are using this participative approach, and this is up in Queensland in the north, just to geographically locate yourselves. They're using a program called Perform, so Participative Ergonomics for Manual Tasks. And in this particular example, the organisation, quite a large organisation, nearly 3,000 people, and they supply products and resources to freight and rail industries. And so they undertook to do this perform process and found a number of processes, not surprisingly. And this particular one was the internal lining of fettling furnaces. What happened was the person on the left, two people undertook the job, and it took 2 days, so four person days per week to do this process. On the left is a photo of the redesign, which now that they've mechanised this, it can be done in 2 hours. So a significant change. The other part of the story is that they had 4 injuries in the previous year, 2 lost time injuries, so people had gone through to claim. So how did they do this? Of course, they used worker knowledge. They used the worker knowledge to help look what was happening in other organisations and to redesign and think through what were the particular issues that they were confronting and what they needed to do to sort them. They had high-level management support, and we know that if you don't have that, it makes it very difficult to get things to work. They trained someone in the perform process to drive, so they had a champion at site level. And we also, most of us probably know that you really need that for that to be successful. They then had someone, a consultant, external to the organisation to mentor that perform champion of the workplace. So what's always good is if you can have a cost benefit to convince management that you're actually doing good things and that it's cost effective for them to make these particular changes. The intervention costs were about $118,000. Post-intervention, about $90,000 in savings, in benefits, and the payback period was about 16 months. So I think you'd agree that's a good news story. Another example using the perform process, again in a smaller organisation. So just to contrast, this one only had 300 people, and they had this process that involved moving that large, unwieldy piece of equipment, which was about 50 to 100 kilos. Of course, that varied depending on how people did it and what was happening with the wheels, etc. Again, they used a participative approach to generate a range of different changes, and what they ended up doing was customising. They used an electric pallet jack and customised a harness so that it could actually move. So still some manual handling, but significantly less forces than were required before. So these are some really good examples of using participation, which is an important part of risk management process. The perform process, however, doesn't specifically address the psychosocial hazards, and I think that one of the developers of that process would suggest that that probably is an area that could be developed further. So, what we're finding in our work and in talking with our colleagues undertaking work in this area is that current MSD risk management strategies don't really reflect what the current evidence is telling us. So usually our approach is more narrowly focused on just the physical hazards. And we have this issue about the single event, which in part is driven by the regulatory system. So it's above all of us. This is a problem that we have to work under and somehow manage. So what's the problem with psychosocial hazards? They have a lot of bad press as being difficult, airy-fairy, not really tangible, and some of that's true. but some of it's perhaps not, and I think we need to be thinking about what actually they are. And we all know that in areas where we work, where we have supervision that is less than ideal, we sometimes have problems. So there are things we can do about that. We can support that supervisor who may well not be well suited to the supervisor role and may need some support, some training to build their capacity in how to manage that. One of my colleagues in Australia has been writing about this and said we actually just need to think about psychosocial hazards in the same way as any other OHS hazard and learn to manage it, and we have to start. And like anything, the more we do it, the easier it gets. We get better at thinking about how to approach it. And I think we've got some pretty good ideas about how to measure it. We just have to accept that measurement is going to be from the workers. We can't stand there with a checklist or an objective tool as we might do with the physical hazards. So it's a different approach. So when we think about an MSD's toolkit, we need to make sure that it incorporates the psychosocial and the physical hazards. And targeting risk management, we found from the work being done, needs to be at job level. So making sure that the solutions are both developed and implemented at job level. And what we did in one of our recent projects is we used some participative workshops with a whole slice of different representatives from across the organisation in developing those risk controls. So we undertook survey assessment and then used those results to actually help generate what controls look like short term, longer term. So what can we do immediately? What do we need to plan for? But the workshop was great, but we need something to ensure that we've got a sustainable solution in MSD's risk management. We are a WHO collaborating centre at our centre, and so we are developing a toolkit underneath the auspice of the WHO. This will look like any plan, do, act model that we would use for our risk management processes, and that's exactly what we want to do, is to develop something that just fits with what people are normally doing. We know as soon as you've got extra things, that these extra things can, drop off the table. There are a number of comprehensive approaches for managing psychosocial hazards in other countries. So Europe, we've got CRE-MSD, some of you might have seen that, PAS-10 in the UK, Canada, the Psychological Health and Safety in the Workplace, and in Australia we have a document called Reducing Stress in the Workplace. These are primarily aimed at reduction of mental health outcomes, and so not specifically for MSDs. One of the issues, so these are fine, they provide very good examples of perhaps how to measure and address things, but not specifically if we're looking at MSDs. And one of the problems is if we're in industries that may not typically be recognised for having psychosocial hazards, we may not be looking at approaches like this. So we're developing this toolkit, which I have in draft form here. They need to be practicable, easy to use, provide guidance and education for people, because we know that one of the things you've got to do is convince senior leaders and management about what you're trying to do in implementing change. This is the healthy workplace model, so looking at the integration between all of those aspects, between physical work, psychosocial work, personal health resources, or those individual factors, and what happens as a whole in enterprise and community involvement. And we know that the role of regulation is particularly important in the area of occupational health and safety and ergonomics. It often influences what we do in workplaces, or how we do things. So we need to take a multi-pronged approach, addressing all psychosocial and manual handling hazards. We need participation from workers, reps, stakeholders, supervisors and management, and then senior management commitment. And I think that will be a theme throughout the day, that when we've got that, it makes it much easier to get things to work. This is just a sketch of what our toolkit looks like. Really important is having a team of people to manage the process, like managing any ergonomic or health and safety issue in the workplace. So we first need to have the team gather all the information we've got, and I put a little caveat on that, that often we rely on injury and incident data or claims data, and we know that if we think back to where we started, that's often at the that's often too late. We need to be going earlier than that and trying to identify things very early on in the piece. There's a role for education of management and supervisors. In terms of actually running the process, we survey staff on a range of psychosocial and physical factors in the workplace, and this enables us to develop a hazard and risk profile, so we know what if there's a problem, and we can use that to then develop risk controls participatively in the workplace. We need to implement and then review, all things we're very comfortable with doing in our current practice. Just skip over that. So we have a draft at the moment, as I've got there. The plan is that it will be interactive, allowing users, I should say, to be able to customise further. So, because of course there are differences between organisations and how they operate and what they're doing, and what are the relevant hazards in their workplace. Of course, you know, they're very different. Healthcare and logistics, it's probably not a good comparison, because there are some similarities, I would suggest, in finding beds in hospitals in Melbourne, and probably no different here. We are in the process of finalising an intervention study, which we hope that we can start later in the year. So, back to the 3 questions. I think the first one we're fine with, that we have a problem. I hope that I've convinced you that the evidence is fairly compelling that there are 2 pathways to the development of MSDs, and that psychosocial and physical hazards are both important, and they will vary, the contribution will vary, and that will depend on the sorts of work that we are looking at, the organisation, how we measure it. And what I would suggest is that we need to think very carefully about how we're currently managing our MSDs, and are we really using an evidence-informed approach? Because that's, as professionals in the field, is what we should be doing, is using evidence. One of the issues as a researcher and a practitioner is about the translation of research into practice, and I know we're going to talk about that later on this afternoon. So we need to be thinking, my challenge to you today is to think about what are we currently doing, and do we need to make changes? So it's always good to hope that people might remember one thing from your from your presentation. And so if I give you 3 points, maybe one of them next week you might go, what was that? What was she talking about? So does your organisation's current policies and procedures reflect contemporary evidence relating to musculoskeletal disorders? So have a look and think about what we've been talking about. Don't step away from the management of psychosocial hazards. They're difficult and challenging, but like anything, once you start, it will get easier. And leadership is pivotal. You need to have someone who's going to champion change, and you need to have support in making changes happen. If you don't have that, then it's going to be very difficult to get that to work. So So thank you. This is, I live in the central Victoria in the middle of the bush, so I live on 60 acres, so that is my my dam. So I have water, which is a rare commodity in central Victoria. And I just wanted to share a couple of, this is where last week I was in Brisbane where it was a balmy 35 degrees and I was walking to get dinner and there were 100 people lying on the grass. So I just thought it was a little bit of a contrast to here where I didn't see anyone sitting outside eating their sandwiches last week when I was in downtown Toronto. And there's a kangaroo, which is on my front lawn, about to eat. You'll see, there's no green grass in central Victoria in February, but we have a little strip around the edge, and so it's come over the fence to try and eat it, and hopefully not my vegetables. Thank you for listening. Are we doing questions?
Yes. Thank you so much, Jody. Thank you. We would love to engage you in some questions. There's certainly going to be time throughout the day, and Jody is here for the entire day, but we have time, so we would encourage you to use your outdoor voice and stand up and ask some questions. George?
I thought I had an understanding of psychosocial factors here, but when you separated out work satisfaction from that in your slides, can you give us a better indication of what you see as psychosocial factors?
So you asking why I talk about it separately, or we measure it separately to the psychosocial hazards? Because by and large, job satisfaction is a personal state, so I'm satisfied or not. The organisation can influence whether I'm satisfied by providing a nice job or somewhere nice to work, but the actual measure of satisfaction is about the person's state. So we separate, and people will argue either way, and our particular belief in the work that we do is that it and work-life balance or imbalance, however you choose to measure it, are personal states as opposed to organisational measures or organisational hazards. Does that answer it?
Partially.
Yes, I didn't think I quite got there.
Yeah, so what factors then? What factors would you include in the psychosocial then if you're leaving that out?
Oh, okay. So the psychosocial, and if I go back, the little table, which is here. Where are we? There. So if we're measuring psychosocial hazards, and I put a caveat here, we use the one questionnaire across organisations so that we can actually do some comparisons. We're trying to get normative data, and so we use a questionnaire that measures a range of these, but what we do is we supplement depending on what the particular organisation is. So we would do a focus group with an organisation before we worked with them, so we could identify, in this one, it's about scheduling, shift work, demands. So in hospital, interestingly, we thought demands was going to be a big issue. It was less of an issue than we thought. We actually included separate measures for demands, but we ended up going back to this work organisation assessment questionnaire. So I would be covering areas such as this, and using, there are a number of surveys. We happen to use this work organisation assessment questionnaire because it's relatively short, relatively easy to interpret, and it has quite good guidance material for organisations to use in terms of developing controls. Does that answer it then? Ah, good, bingo. Yep.
Patrick Newman, Ryerson University. Thank you for your talk. I'm wondering why we don't do a better job tying psychosocial factors to human resource constructs like motivation, engagement. I mean, these are the things that managers want.
You think, sorry, could you just start again?
Well,
you think we do have to?
I'm wondering why we haven't, or if it's just not spoken of here, right?
Yeah.
Because the managers want the good things. They want motivated,
Yeah.
healthy, engaged employees, and here we're talking about all the bad things.
Right, okay, so you think we need to spin it differently. Well, I think that you're right about the engagement, the better dialogue with managers, with management and HR. And I think one of the, maybe this is one of the barriers to implementation.
That's, I guess, what I was getting at. I was also wondering what the evidence is, because those are two different groups of researchers doing two different kinds of research on similar constructs, right?
Yeah.
So there seems to be a gap here.
I absolutely agree, and we're about to start a project exactly on barriers and enablers to introducing new ways of managing risk in organisations. And on that team we have people from management and, which area are you from?
Industrial engineering.
Right. So, and if you've worked with people from the management side of the university, we have different dialogue. It's quite hilarious to sit in a room. You really have to we have to get a dictionary out to make sure we're talking about the same thing, and I think that's a problem. I think we should actually be talking about the same thing, so I agree.
Thank you very much.
Other questions? Maybe you can just, right here. Jack. So you're getting your exercise.
Hi, Jack Callahan, CRE-MSD. Very much a mechanics person, so I want to ask you about how these go together, because part of it, I'm sure, is just semantics, because it's easy to see how somebody gets hurt from mechanical exposure. Yeah. So you remove those identifiers or those factors, posture. You had two really nice examples there. But how somebody gets hurt from a psychosocial hazard is a little beyond me. I can see how it affects claim rates, but not actual MSDs. So a question out of that statement is, you had two examples, and one of them I could see, the one with the electric push cart, right? So you nicely change force and posture, and I could also see how that person's satisfaction would go up, right? The health and safety culture, since we have this slide up here, the high workloads would go down, so very valuable, right? Where your other example, you essentially replaced that person's job. Right? It's been great from a company perspective, but you had 4 workers there who now are not being valued, to put it in your social context, and may not even be there. So how do you fit those together, and when you have obviously very positive changes from an MSD prevention perspective?
Yeah, it's one of those things. I thought that is a very good question, and I was thinking yesterday, if someone asked me about that, what's the right answer for that? I think we have to, one thing is, do we keep doing something so that someone doesn't lose their job? And I think the answer is that we can't say that. We can't not fix things because someone might lose their job, because we're injuring people. So they can't work anyway. So at least they don't have a job and they're not injured. But I think the process of how they got there in doing that was one of engagement. Now, I said that process doesn't specifically include identification and management of psychosocial hazards, but they're sort of there by proxy. So you've got engagement because the workers are being involved in developing the process. So they're there all along. And yes, someone still has to drive the mechanical things. So someone had to they had to train a couple of people in how to actually do that process. So in essence, you've got them out of doing the grunt work into something a little, more expert. And yes, we've removed people from doing that other hideous job. But I would suggest that if we're not doing our job, if we don't do that.
So maybe paraphrase my first part of that. Soliloquy or rant, however you want to call it. So in general, I would say if I change the musculoskeletal exposure,
Yep.
I think I can influence psychosocial hazards. Can you change musculoskeletal exposure by intervening on psychosocial hazards?
Yes, I would suggest you can. Because if you're doing a crappy job, that you've got, a boss who's on your back all the time, you've got scheduling, you've got role conflict and those things, then you can make a change to those things, then are you going to change those physiological responses? I think you are. It's just different to, it's perhaps less obvious in terms of the postural aspects in what people are doing. But I mean, there are postural examples. If the people are under stress, they hold themselves differently. Their muscle tension is an issue. So
That's what I was going to say.
Yeah.
The internal.
Yeah. Yeah.
Stress.
Exactly.
Muscle activity.
Yeah. And I like using Bill Marin.